Thank you very much. It's a pleasure and a privilege to be here today with a great friend Arturo and with all of you. Today I've been asked to speak about bicuspid valve disease, something I've learned a lot from Arturo about over my career. And I'm going to incorporate what was written in the 2022 ACC guidelines, the 173-page document that has a large section on bicuspid valve disease and the aortopathy. Of course, imaging the bicuspid valve is critical by echocardiography, recommended in all to understand the function of the valve, the presence of coexisting congenital lesions, and to assess the aorta. And the guidelines specifically mention the importance of entirety of aortic imaging. So if the echocardiogram doesn't discern the entire extent of the aortic enlargement, then cross-sectional imaging by CT or MR is indicated for that understanding. The next part of the guidelines emphasizes the genetics of bicuspid valve disease, giving a class 1 recommendation for imaging those with bicuspid valve disease who are recognized to have aortopathy. So aortic dilatation present, we recommend screening all the relatives for that. And if, again, not seen adequately by echocardiogram, then imaging by CT or MR. But a class 2A indication, meaning it's reasonable to screen first-degree relatives of the proband with bicuspid valve for bicuspid valve disease. And much of the information comes from Spain. So family studies report the prevalence of bicuspid valve disease in first-degree relatives to be about 9 to 10%. Again, overrepresented compared to the 1% or 2% in the general population. And many groups have now recognized that aortic enlargement is well documented amongst the family members of the proband, even when a tricuspid valve is present. And the largest study to date of over 724 first-degree relatives of 250 bicuspid valve patients, again, here from the group from Valhebron, 6% bicuspid valve disease in this family, 10% of tricuspid valve with isolated aortic dilatation. Again, this made that into the recommendations in the guidelines emphasizing the importance. So the inheritance of bicuspid valve disease, and in practice, when I see somebody with bicuspid valve disease, especially when there's aortopathy, I wonder, is it the valve alone? Do they have bicuspid valve disease alone, or do they have some other genotypic abnormality that's syndromic or non-syndromic? And a recent analysis indicated that screening by echocardiogram, the first-degree relatives, is cost-effective to look for bicuspid valve and or aortopathy. So in the guidelines, the statement was written in patients with a bicuspid valve with heritable thoracic disease or phenotypic features concerning for Loeys-Dietz syndrome, then medical genetics evaluation is recommended, emphasizing the importance of recognizing the subtle features that can be present in some with genetic aortopathy. In the world of bicuspid valve disease, there are those with aneurysm, there are those with syndromic aneurysm. The Loeys-Dietz genes are overrepresented, others with Turner syndrome, of course, and then the non-syndromic heritable conditions with recognizable genes may have an increased prevalence of bicuspid valve compared to the general population. Patients who have Loeys-Dietz syndrome, due to one of the 5 genes that's recognized to cause the phenotype, have a higher prevalence of bicuspid valve than the general population. When we looked at our series from Washington University of bicuspid valve patients with Loeys-Dietz that are entered into the Montalcino Aortic Consortium, you can see the representation here in some of the genes with the prevalence of bicuspid valve. Again, more common in Loeys-Dietz patients than in the general population. So what features should one look for? Again, cardiologists have to become dysmorphologists and look for these features that can be subtle, involving the craniofacial features, the skeleton, and the cutaneous features to recognize the patient that doesn't just have bicuspid valve and aortopathy, but has another condition. So while it's a genetic condition, the genetic causes really remain elusive. And for most patients with bicuspid valve and aortopathy, the genetic variant is not present. In other words, we don't recognize a specific gene to say it's causative. And in large studies, rare variants in Loeys-Dietz genes are not more common among non-syndromic bicuspid valve disease, even with aortopathy. The patients that I would consider genetic testing for or further evaluation are those with phenotypic features of a syndromic aortopathy. So again, looking for the subtle features. I pay a special attention to those with root phenotype and significant aneurysm disease, especially when present in very young individuals. And of course, those with bicuspid valve that have family history that sounds suspicious with heritable disorders or familial thoracic aortic aneurysm disease. We talked about imaging. Imaging for life is required in those with bicuspid valve disease, and the guidelines emphasize that for those without valve replacement when the aorta is 4 centimeters or greater with periodic imaging, and those after valve replacement or repair because the aorta can continue to dilate, but emphasizing the interval of aortic imaging is dependent upon the size, the age, and the prior imaging. This was already talked about in detail in Hector's talk, but aortas grow at different sizes in bicuspid valve disease. Lots of papers in the literature, but generally they grow slowly, and a small segment of aortas grow more rapidly. But it is important to emphasize that the larger the aorta, the more rapid it typically grows. And again, over a lifetime of follow-up, aneurysm disease risk does occur for individuals being followed with bicuspid valve disease. The reason for preventative surgery has been emphasized because bicuspid valve with aortopathy is a risk factor for dissection. That risk is small when the aorta is small, but when the aorta is large, there is still a risk. Now, this was already mentioned in the earlier talk about the heightened risk when someone gets older and the aorta gets bigger. In this table taken from a book chapter that we wrote, the bottom line is aortic dissection. And in the paper that Hector has under consideration now, a small risk of dissection. And in most papers, there's a very small risk in populations of bicuspid valve patients for dissection as long as the aorta is small and they're under watch. And you can see some of the papers here that we listed in this article have very high dissection risks. Of course, those are special populations, again, with larger aortas and tertiary referral centers. So the ACC/HA guidelines incorporated this information and is consistent with current practice that an aortic diameter of 5.5 centimeters or greater is large enough to recommend a prophylactic replacement of the sinuses and or ascending aorta for appropriate candidates. And then shared decision-making is required between 5 and 5.4 centimeters with a Class 2A indication, meaning, again, it's reasonable to proceed in patients that have additional risk factors or require aortic surgery itself at aortic valve surgery itself at 4.5. And then a special group where it may be reasonable to consider, this is a Class 2B, would be for lower risk individuals at that same diameter sharing risks of surgery versus risks of aortic outcomes. And again, just as emphasized in Hector Michelina's talk, the risk of complications of surgery is different for the individual. It's based on one's age, other risk factors, and of course based upon the competence and expertise of the surgeon and the center. Looking at the recent STS data, isolated ascending aortic replacement surgery in all comers is reported to have about a 3% risk of mortality and 3.2% risk of stroke. If you look online at the Cleveland Clinic, the most current data to date would report a 0.6% operative mortality for elective ascending surgery. So when we approach patients that are at these competing risks of observation versus risks of surgery, I often now look at the patient and say, which risk are we going to accept? And it depends for the individual. And do we really know what's the risk for all comers who have bicuspid valves of moderate to large size? 5 centimeters in males versus females, in a young person with root phenotype versus an old person with ascending phenotype, of small body size versus large body size. And what about other risk factors for aortic dissection? This large series was published in 2015 from Cleveland Clinic looking at 1,000 bicuspid valve patients with moderate aortic dilatation. Most had surgery because of valve surgery at this size. Again, a large surveillance group that didn't have surgery that can provide some information about ongoing risk. So 380 patients with aortic sizes of 4.7 centimeters or greater followed for 3 years minimum, some for quite a long duration of follow-up. About half of those patients had aortic surgery and follow-up. And again, very similar. It's frightening how similar these incidences are now that I'm going to take you through, just like in the paper that Hector presented that's in press now or under consideration, 2.6% aortic dissection risk under observation. And you can see the mean diameters are, of course, right in the range under observation. And again, they came up with a intricate risk-adjusted probability of dissection to be about a 4% risk when the aorta was 5 centimeters in the sinuses, 5.3 in the ascending aorta, again kind of emphasizing the root phenotype as an additional risk factor, and also gave credence to aortic size indexed per height ratio, and a much bigger hinge point, of course, at larger diameters. This is a paper from Torsunt's group and others at Mass General looking at the risk of dissection in the moderately dilated ascending aorta, emphasizing the low risk of aortic catastrophes when the aorta is relatively small in the absence of syndromic aortopathy. But you can see on the top slide to my right that the absolute incidence of aortic dissection is somewhere between 1 and 3%, again, under watch for aortas of 5 centimeters or greater. But up to half the patients under watch had elective surgery while under watch. There were very few bicuspid valves in this population that had large aortas, yet that was a very strong component of the paper emphasizing the relatively low risk for bicuspid valve patients. There was 14 dissections in this series, 1 with bicuspid valve, but only 9 patients with bicuspid valve and an aorta more than 50 millimeters that had follow-up imaging. And the average growth of the bicuspid valves was twice the size of tricuspids in this cohort. Moving on to a very important paper by Matt Solomon and the group at Kaiser Permanente looking at thoracic aortic size and long-term follow-up. So you can see this large population in Kaiser Permanente, millions of lives. They classified the aortic size in many patients, and you can see to the right, many patients under watch at 5 centimeters or greater. These are all comers, but they also looked at the bicuspid valve patients, and they did a predicted risk of a dissection over 5 years if the aorta didn't change in size, which is the darker hash, and if the aorta changed as one would expect over size. And you can see the circled area of the 5 to 5.5, 5.4 centimeter, about a 3% risk or so of aortic dissection under watch. And looking at a more granular manner of the individuals in this group between 5 and 5.4 centimeters under watch, a quarter of the patients died, 1% had dissections, 40% had surgery. And if you compared the low risk of 1% of dissection and the high risk, of course, of death at 8%, there's going to be a risk somewhere in that range for people under follow-up to have a poor outcome. And again, looking at the dissection events, they were rare. Amongst the 747 patients with bicuspid valve disease, there was only 1 of 44 aortic dissection events that was a bicuspid valve patient. Finally, the group at Yale looked at 1,000 patients with unoperated thoracic aneurysms followed over 8 years and codified adverse ascending aortic events, dissection, rupture, or aortic death. And again, looked between 5 and 5.4 centimeters, the average yearly risk about 1.4% of one of these events under watch. But an interesting part of this paper is the long-term survival. So if you look at 10-year survival free of an adverse aortic event, it was 85% when your aorta was between 5 and 5.4. So I think that's useful information when you think about timing of surgery, especially in younger people that have long lifespans that have to accept the risk of the surgery and, of course, the risk of an outcome when you think about long-term. And in this group, the bicuspid valve did not overrepresent risk. It was similar to tricuspid valve patients. And finally, this paper in Press looked from the same group, looked at aortic diameters and long-term adverse aortic outcomes in a very large group, almost 2,500 patients, of which 500 had bicuspid valves, and looked at growth rates, adverse aortic events, and risk of complications. And again, you can see the hinge point for an adverse aortic event in these bicuspid valve patients between 5 and 5.5 centimeters being in a range of about 1 to 5%. And there was no difference in this risk at about 1 to 2% at an aorta of 5 and a higher risk of about 3 to 5% as the aorta got larger. So thinking about when to do surgery and the guidelines that we wrote, again, there's a lot of shared decision-making and a lot of factors that go into this. It's not just the size alone, the age, the risk, other factors regarding phenotype of the aorta, family history, patient's wishes. And again, when we think about lower risk patients with smaller aortic diameters, young age, family history, rapid growth, root phenotype, females with small body size predominate aortic regurgitation, which associates with more cystic meal degeneration and, of course, a low surgical risk, versus those that we weight have higher surgical risks and probably lower risk outcomes. So I want to end there and thank my friend Arturo for a wonderful career. When I think about bicuspid valve, I think of you. When I think about the form Frust or mini RAF, I think of you. That's a concept that's still not known by most. I think that's a game changer in this field. You've been a great friend and colleague. I've learned from you in the aortic world, in the genetic aortic world, your contributions to things that we have so much interest in together, the IRAD, the Montalcino Aortic Consortium, the Marfan Foundation, and patient care and advocating for the outcome of the people you see. When I think about which papers I try to read, if I see a paper that has your name on it, I always read it, and I always take away something. So thank you very much for all that you've done, and I wish you a wonderful semi-retirement.